Welcome back to Basic Concepts, talking about perioperative nursing care. We're going to change our focus to care of intraoperative patients. And intraoperative period begins when the patient enters the surgical suite and ends at the time of transfer to the post-anesthesia recovery area, also known as the PACU, or post-anesthesia recovery unit. So you will hear me use the term PACU oftentimes throughout when I am talking about our patients, especially when we get to that post-operative period. Things that we need to consider as an OR nurse is that it requires an RN to be a circulating nurse. You can have either an RN or an LPN or a tech be of the scrub person that is in those in the surgical suite as well. Nursing care during this time is going to be really critical because we still need to meet all of our patients' demands. We need to meet our patients' needs physically, spiritually, safety, dignity. Dignity is very big because, as I said when we talked about pre-op, was perhaps shaving the perineal area or areas that might cause the patient embarrassment. Well, just because they're in surgery and asleep doesn't mean that we should whip that sheet up and leave them exposed for everyone to see. So we do need to remember our patient's dignity. Keeping the patient warm in the very cool environment is going to be important as well. So when we consider members of the surgical team, you can see that we have a big list on this slide, anywhere from the surgeon to technologists. You will see many different people inside of the surgical suite, but basically, as I said before, you have to have an OR nurse circulating, and then you also will have a scrub nurse who is either a nurse or a scrub person, being an LPN or a tech. The number of assistants is going to depend on how in-depth the procedure and how complex the procedure may be. But typically the people that will make it up, the surgeon and his or her assistant, they're going to be the ones that provide the surgical care. The anesthesia providers can be an anesthesiologist or a certified registered nurse anesthetist, CRNA, and they're going to be the ones responsible for monitoring our patient during the anesthesia. So be it a general, a spinal, an epidural, a local, a nerve block. The nurse anesthetist is going to be responsible for that. So the patient will be on an EKG monitor. They'll probably have oxygen. If it's a spinal, they'll be on ventilatory support if it's a general anesthetic. So we will be using heart monitoring, pulse oximetry, end-tidal carbon dioxide monitoring, and then they will be responsible for maintaining IV intake so that our patient is getting adequate hydration. They will also be responsible for recording the I&O, so if our patient has a Foley catheter, they'll be responsible for that. And then the vital signs, of course, and typically vital signs occur about every 5 minutes, but the thing to remember about that is it may be a specific time frame that says they have to do vitals every 5 minutes, but it is very dependent upon your patient's condition. So if you were to see a test question regarding frequency of vital signs, I would say that you should answer, hint, hint, that it will be dependent upon your patient's condition. The nursing staff will have many different roles. The scrub nurse is the nurse that is in the operating room and is responsible for maintaining of asepsis during the procedure. So the circulator makes certain that it is safe and that the room is functional. He or she will attach safety straps, arm boards for patient positioning, either heating pads or warming blankets if the area is really cold. Throughout the procedure, the circulating nurse will protect the patient's privacy and ensure their safety. He or she will be responsible for monitoring the traffic, so who's coming in and out of the room. We'll also be looking for the amount of urine and blood loss, report any abnormal findings to the surgeon or nurse anesthetist. And then, as I said, the sterile technique And also, as you can see on page 266, the circulator hands off the non-sterile equipment while maintaining sterility to the scrub person. So your scrub nurse then, or scrub person, sets up that sterile field, and once that person goes in and has donned all the sterile gown, gloves, mask, those types of things, that person stays in that room with that equipment. And so with that said, you know that you can't turn your back on equipment, you can't lower your hands below the level of your waist. And so that person will set up that sterile field that will include all the sterile supplies, all the sterile equipment that the surgeon might need. It's really important for that surgical nurse to have a good knowledge of what all those instruments are. And then with that knowledge, they need to almost anticipate the next step of the surgeon so they can be ready to hand off any of the equipment that they may need during this time. During the laparoscopic procedures, the room pretty much stays the same. However, there will be someone controlling the cameras and equipment for the surgeon so that can maintain that sterile environment. So this next slide shows just a couple of pictures. This first picture here is actually a true setup of a surgical suite. You can see we have lights up here, and actually on the handles of those lights, they do put sterile coverings so the surgeon or the scrub nurse or circulating nurse can move those around as necessary. And then this big machine over here is going to be the machine that your nurse anesthetist or your anesthesiologist uses to monitor that patient during those surgical procedures. So there is definitely a lot of equipment involved, many things to set out and have organized prior to our patient entering this room. And really our surgeons are very reliant upon the nurses and surgical techs and things like that that are helping out during surgery. Minimally invasive or robotic surgery, very common to see these things being done. You know, when I started nursing over about 20 years ago, it was not so common to have all of the laparoscopic procedures done. We did many open cases. We had patients staying for a long period of time. So with the invention of the endoscope and the robotics that are developed to do specific procedures, we're definitely seeing greater advantages for our clients. You know, decreased infection because we're not making those large open wounds. People aren't staying in the hospital for very long, so they're not really at risk for developing hospital-acquired infections. The patient preparation for endoscopic surgery is going to be very similar to the preparation for a patient undergoing an open case. So really, you know, great strides have been made in surgery and anesthesia over the course of, you know, many years. So that is one good thing. You will take a peek at this picture, and you can see by this picture they are using a laparoscope to go in and remove maybe the fallopian tube or tie the fallopian tube. But what they do is they inject air with the laparoscope, and so they inject carbon dioxide into the patient's abdomen to kind of like blow it up like a balloon so that the organs sit inside of this area, and then the scopes and clamps and lights are inserted into the patient's abdomen, and then the physician will maneuver outside of the patient's area. So, you know, it's really very great technology that we have, and our patients go home typically with just some stab wounds from the scopes going in. So with a gallbladder, it's very typical to see patients having 4 quote-unquote stab wounds from the instruments being used. Say for the patient having a tubal ligation, typically they just make a small incision in the belly button or right below the belly button, insert the instruments that way, and then the patient is ready to go. So we are seeing much, much better outcomes, decreased recovery times for our patients. Some possible injuries that could happen: mechanical trauma, thermal injury, maybe malfunction of the equipment. So that being said, you need to go back and think about your patient's safety. We need to ensure that this equipment is being looked at, and inspections are being done so that our patient is going to be kept safe that way. Also, a potential, and it's not really a potential injury, but a potentiality of the MIS surgeries is that maybe it will have to turn into an open case if they aren't able to complete the procedure done via laparoscope. So sometimes cases may be opened, and patients do sign a consent that requests the surgeons do what he deems advisable. And so say they went in to do a laparoscopic cholecystectomy, so they're going in to remove the gallbladder, and maybe there's too many stones, the gallbladder is too enlarged to fit through the laparoscope to get out. So then they'll do an incision and take it out that way, because obviously we don't want to wake the patient up and say, oh, I'm sorry, I just wanted to let you know that we're going to open you up and take your gallbladder out that way. So no, we don't wake the patients up. The surgeon will typically send someone to visit with the family, let them know what's going on, and then they can move on with the case. As far as the environment of the operating room, safety of the team as well as safety of our patient is going to be important. The layouts are very, very similar from institution to institution. The biggest idea is that traffic flow is very much reduced in a surgical area. So oftentimes it'll be off in a hospital on its own wing, its own floor, its own area, basically, so that we don't have a lot of contamination being accessible to our operating rooms. It's divided into 3 zones. There's an unrestricted area, and that's a lot like your same-day surgical area where your patient's getting prepped and getting ready to go to surgery. The surgical team typically has surgical scrubs on, maybe shoe covers, but oftentimes won't have the hair covering or mask on in these areas. The next is a semi-restricted, and that's kind of the final area prior to entering the surgical suite that only clean, quote unquote, clean people can be, and they have to have their hair covered, shoes covered, and then the proper surgical scrubs that are at the hospital already, because we don't want people wearing scrubs from the outside into those operating rooms, because that will just increase the risk for contamination. And then the restricted area is actually the surgical suite itself where a surgery is going to take place, and that is going to be the cleanest place. The surgical team is required to wear the scrubs, the shoe covers, the hat, and then they're also required to wear a mask over their mouth and nose so that they don't bring any of those kind of contaminants into the room. Oftentimes the surgical team themselves scrub the rooms between cases to ensure that it's done very, very thoroughly as well. The size of the surgical suite is going to depend on what the capabilities of the facilities are, but all of their equipment is going to be housed within that area and really not accessible to any other department. So remember, people are the source of bacteria. So we have our patients scrub the night before, the morning of. We scrub them when they come to us. Then they will go to the surgical suite, and guess again, they're going to get scrubbed one more time. We really are trying to control any kind of bacterial contaminations. So there's definitely special healthcare standards. There's special codes that everyone needs to watch and follow, and we definitely want to prevent any nosocomial infections. If you don't know what nosocomial infections are, you need to take a minute and pause this, get a book out, and look so that you understand what those are. Because if our patients get nosocomial infections, guess who's going to pay that bill? The hospital. Medicare, Medicaid, insurances, they're not paying for any of those nosocomial infections that patients get while they're in the hospital. So it's very, very important that we keep this environment very clean, as sterile as possible, and then when it comes to the actual surgical time, that everything we're using is sterile.